Okay, so now we're ready to start talking about the general senses, those senses that are found distributed throughout the body, especially in the skin, around joints, and visceral organs. So the general senses include the the senses of touch, pressure, stretch, vibration, temperature, pain, and proprioception. So lots of different types of stimulus are included in the general senses. And we'll start by talking about the touch and pressure senses. There are three receptor types, three receptor types that can help to produce the touch and pressure senses, and they're all stimulated by movement or deformation of the receptors in some way. So these are mechanoreceptors that do this kind of work. The first kind are in unencapsulated dendrites. Another way of saying free nerve endings, because they don't have any capsule that wraps around the tip of those nerve endings. So these free nerve endings, or unencapsulated dendrites, are just swellings at the tips of the sensory neuron dendrites. And they have these knob-like endings, and they're found pretty much throughout the body. But they're especially common in epithelial tissues and in connective tissues. Encapsulated dendrite endings, these are sensory receptors where the tip of the dendrite is enclosed in a connective tissue capsule of some sort, wrapped around with one or more cells. And again, most of these are mechanoreceptors. There are two types of these encapsulated dendrite endings. They're the tactile corpuscles, also called the Meissner's corpuscles. And if you remember back to when we talked about the skin, we saw that these tactile corpuscles are found in the dermal papillae. So those little the little hills of dermal tissue that are there below the epidermis. And they provide that light touch sensation. And they're especially numerous in hairless skin. So the skin of the lips, the nipples, the external genitalia that are hairless. There's also lamellated corpuscles, also known as Pacinian corpuscles. These were ones that were found deeper in the dermis and even in the hypodermis, those subcutaneous tissues. And they provide information, or they respond to stimuli like deep pressure and vibration. And again, also encapsulated. They have connective tissue cells that are wrapped around the end of them. They're scattered throughout the dermis and hypodermis, but especially in the hands, the feet, and as well as the urethra and external genitals. All right, so three types. We've got unencapsulated dendrites, the tactile corpuscles, and the lamellated corpuscles. Those are the three types. And the Meissner's and Pacinian corpuscles, they are both types of encapsulated dendrites. Temperature senses are they are sensed by by free nerve endings. It's the free nerve endings that do the sensory reception for temperature sensing. And there are two types of receptors: cold receptors and warm receptors. Cold receptors are found in the superficial dermis, and they're insensitive to decreasing temperatures. And they have a sensitivity range somewhere between 10 and 20 degrees Celsius. In Fahrenheit, that's 50 to 68 degrees Fahrenheit. If you get colder than 10 degrees Celsius, then that will stimulate pain reception rather than cold, that sense of cold. So the cold receptors go inactive at temperatures below 10 degrees C, and it's only pain reception that we feel. And they're relatively abundant, especially compared to the warm receptors. Warm receptors are found in the deeper dermis, and as the name suggests, they're sensitive to increasing temperatures. Their greatest sensitivity is between 25 and 45 degrees Celsius. That's in Fahrenheit, that's between 77 and 113 degrees Fahrenheit. If you get hotter than 113 F or 45 C, then rather than stimulating warm reception, what we get instead is pain again. Now notice, I think this is interesting, well, here, see, that there's like a little gap in temperatures where neither the warm receptors nor the cold receptors are active. So here between 20 and 25 degrees C, which is the same as 68 to 77 degrees Fahrenheit, there is no sensitivity to temperature. So this would make sense then that we prefer room temperature between 70 and 72 degrees Celsius. So here in this range where there is no temperature, there's no activity in either the warm or the cold receptors. And that, so that makes sense that room temperature would be most comfortable there, because we're not noticing, ooh, I'm chilly, or ooh, I'm hot. Whereas with drinks, nobody wants to have a drink, or very few, here in this range of 68 to 77 degrees Fahrenheit. Nice big glass of lukewarm milk, or so we prefer to have beverages that are either iced or are hot, so that we are getting information about the temperature of what we're drinking, because it's that's what stimulates us. That's what it captures our attention and makes us go, that was tasty. So this range of temperature here, that's 68 to 77, or 20 to 25 if we're thinking in the Celsius scale, that those are important temperatures to either maintain if we're thinking about comfort in to our skin, or to avoid if we're thinking about sparking some interest in the mouth. Pain receptors are also free nerve endings, and they're stimulated by anything that damages tissue. So being deformed or pressed or smashed, if they get smashed, if they get squeezed, then pain receptors go off. But they also respond to chemicals. So they may be mechanoreceptors, or if they respond to chemicals, then they're chemoreceptors. And the point of pain, being able to recognize pain, is that we want to notify our central nervous system that, hey, we've been injured, we got to do something about that, or stop doing whatever we were doing, because that injury is going to hurt us. While we've already talked about adaptation, and with temperature, those warm and cold receptors, we see very rapid adaptation within several seconds to a minute. We stop noticing, we stop receiving information about what temperature we are subjecting the skin to. With pain, though, it is very slow to adapt to stimuli. And sometimes, or some pain receptors do not even, there's no adaptation at all. They're just not capable of that. And that also makes sense. We need to be aware of painful stimuli because we're hurting ourselves. And we can classify pain signals based on the region of origin. So somatic pain and visceral pain are two categories of pain signals. Somatic pain originates at the skin, in the muscles, and the joints. Superficial somatic pain, we talk about that as sharp or prickling pain. These are usually short-lived, and the source can be localized to the affected region. So, we're capable of noticing where it is that that these sensations are coming from. This would be pain carried along type A fibers, or fast pain here that we're talking about. Deep somatic pain is usually indicative of, or is indicative of tissue damage, and usually provides an aching, burning, or itching type of sensation. It's a longer lasting than superficial somatic pain, the sharp prickling pain, and because of the size of the receptive area, it can be really hard to determine where that deep somatic pain is coming from. Carried on those type B, the slow pain fibers. And then finally, visceral pain that originates at damaged tissues that are found in the thoracic or the abdominal cavities. Those organs are what we talk about as the viscera. And it's a dull, aching, gnawing, burning kind of pain. So again, type B pain fibers is what visceral pain is carried along. And once again, the location, or that source of pain, may be difficult to determine. Now, pain does a really interesting thing, or our brain does an interesting thing with pain. And this phenomenon is called referred pain. And there's a great, I don't have my book open right now, but there's a good figure in the textbook that shows referred pain. With referred pain, the pain sensations seem to come from a different part of the body than where the pain was actually stimulated. And referred pain can be very characteristic of visceral pain. So this is the reason that when people are experiencing a heart attack, one of the symptoms that the patient will report is that pain is radiating down the left shoulder. Radiating to the left shoulder, or even down the left arm. So that referred pain that makes it feel as if the pain is in the shoulder and radiating down that left arm. That's what we talk about as referred pain. Kidney pain may be referred to the area around the waist and down the inner and outer thighs. And liver and gallbladder pain can be referred to the right shoulder. So really strange phenomenon here. It doesn't seem to, there's not a lot of sense to it. And so this is something to be aware of. You could have a patient sitting in there, lying in bed, or sitting in their room, and they're talking about, my shoulder just really, really hurts. That might be indicative of gallbladder issues. So being aware of where different organ pain is referred to is very important. As well, rather than sensing the pain, like stomach pain, deep in the body, frequently visceral pain is referred to the surface of the body, near to where that, just the superficial to where the organ is and where the pain is in the organ. So referred pain is just this unusual phenomenon, and being aware of some of the patterns in referred pain is important. And the reason that referred pain happens is that because the afferent fibers that are bringing in that pain sensation to the central nervous system, they use the same pathways as somatic pain fibers, the ones that are transferring the that are transferring the somatic pain to the central nervous system. And so there can be some confusion once those signals reach the brain about what's happening. And so projection of the pain sensation can go out to an inappropriate region. Last little note about referred pain is that pain that originates from the parietal membranes, so the pleura, the pericardia, and the peritoneum, all of the parietal versions of the pleura and pericardia and peritoneum, they are usually not referred. So those pain sensations seem to come from the area where the damage is happening. Pain impulses are carried from pain receptors on one of two fiber types. The acute pain fibers, or the A fibers, fast pain fibers. These are fine myelinated fibers that transmit signals quickly, so they can travel at speeds of anywhere between 12 and 30 miles per second. I'm sorry, meters per second. That M is for meters. And acute pain fibers are associated with sharp or prickling pain associated with the skin surface. And when you remove the stimulus that's causing this acute pain, then generally the pain ends. So we're done with pain when the stimulus is removed. On the other hand, pain that is carried on chronic pain fibers, the C fibers, these are smaller, unmyelinated fibers, and so because they don't have myelin, they transmit signals more slowly, somewhere between 0.4 and 2 meters per second. These are the pain fibers that are associated with dull, aching pain that's coming from deeper tissues. And these pain fibers will continue to send pain impulses even after the original stimulus is removed. And this is why pain, that dull aching pain especially, sticks with you. The pain fibers then synapse with interneurons in the dorsal horns of the spinal cord. So they're on the dorsal surface where those sensory neurons are coming in and synapsing with the interneurons. And then the axons will decussate and transmit information then to the thalamus, the hypothalamus, and then forward on to the cortex to be interpreted. So again, if the fibers are decussate, that means that they cross over. So pain sensations that originate on the right side of the body are interpreted up on the left side of the brain. So pain threshold, there's one, this is another phenomenon associated with pain. Everybody's got the same pain threshold. So that's the amount of stimulus that's required to initiate an action potential. Remember what threshold means. But everyone has a different pain tolerance. So how the brain interprets pain and what it does with pain is different from person to person, and it's the variance in pain tolerance is great. It may be affected by how long the pain has been felt. It can wear you down and become your tolerance becomes less and less over time. It can vary with age, with cultural factors. In some cultures, your tolerance of pain is much greater than in others, and with psychological factors, depending on how emotionally distraught or upset a person is. So, interestingly, under extreme stress, a person can be severely injured yet have no perception of pain because they're really engaged in whatever the stressful event is that's going on. I've also seen, this is personal experience now, though, that being emotionally upset, let that happen. Being emotionally upset may make it, may reduce pain tolerance, and so I know that when my daughters are upset, then they respond even greater ways to pain, and it feels even more painful. is how they report talking about their pain. Okay, and then the last of the general senses that we're going to be talking about then is proprioception. Proprioceptors are dendrites that are found encapsulated in a connective tissue sheath, and they provide information to the central nervous system, both about the length and the tension found in skeletal muscles and in tendons. But we don't create a perception of the sensations that are brought to the central nervous system. So rather than having a conscious thought about it, the proprioceptors are really providing information to the unconscious parts of the brain so that you can use that information in other ways. There are two primary types of proprioceptors: the muscle spindles. These muscle spindles are found located in skeletal muscle tissue, and they're composed of anywhere between 3 and 10 of these modified skeletal muscle cells called intrafusal fibers. And as muscles stretch, these muscle spindles notice that stretch and will initiate a reflex, a stretch reflex, that causes the muscle to contract, and that helps to maintain the position of the limb in whatever position that we're trying to maintain. A second kind of proprioceptor is the Golgi tendon organ, and these are located in tendons near where the muscles attach to the tendons. And these Golgi tendon organs are stimulated as muscle tension increases, and as that muscle tension increases, it initiates a reflex that helps to inhibit, or that causes inhibition of muscle contraction. And so again, this is all about maintaining the position of limbs and maintaining posture in the body. And it can also protect those tendons from being overstretched and damaged. So it protects how the muscle attaches back to the bone.